reliable screening tests, but there really isn't a lot of really good evidence backing that up. So here are studies looking at people who have BRCA 1 and 2 and looking at these remarkable hazard ratios on these larger trials that are prospective or retrospective in nature. But what happens here is that for ovarian cancer and breast cancer, we've got significant reductions if you remove the ovaries for both hazard ratios of 0.15 and 0.32. And I think that this is what needs to be done, but again, it's only for that very small 10% of women who are getting tested, who you can, reduce it, risk reducing in that population. And all the evidence seems to show that that is an effective and clinically important thing to do, and it may be even more important for BRCA1 than it is for BRCA2 patients. So for the risk-reducing cancers, now, this is from, I reviewed this, and she got this early on, but this is out of Memorial Sloan Kettering with Noah Koff's data. And looking at this column, women who had 325 had risk-reducing salpingo-oophorectomies. 3 went on to develop cancers, unfortunately. But in the surveillance group, those who didn't and were getting followed, out of 173, 10 cancers in women who didn't get risk-reducing. So it really does work. Obviously, you're never going to reduce it to 0 because of the primary peritoneal issue, but that is statistically significant. So the timings of import and the discussion has to be made because it does impact when you are going to plan your families. And when you're removing these ovaries, it's not just about, you don't want to leave a little piece of tube or leave a little piece of ovary behind. We call that ovarian remnant syndrome. You want to be able to dissect out the ureter so you can actually follow the infundibulopelvic ligament and isolate the vessels and go through a large enough margin so that you're not leaving little pieces behind for ovarian remnant syndrome or for the potential for developing ovarian cancer in that small piece that's left behind. So as much fallopian tube as possible. Again, here's the ovary for those of you who aren't surgeons, and here's the fallopian tube, and we've got a ligature device here, it looks like, on the IP ligament. So the timing of the procedure, you want to do this before the menopause because the BRCA, usually it's done in the 40s. For BRCA1, you have a 21% risk by the time you're 50 of getting ovarian cancer. For BRCA2, it's 2 to 3% risk by the time you're 50. So I have a couple of patients with this BRCA2, and I share a couple of patients with the oncologist. So, she's getting exams twice a year. She's BRCA2. She already had her ovaries removed, and then she gets 6 months exams, one with me, one with the oncologist. And it's not just about the exams, it's also about reviewing the symptoms. Someone after the last talk, I was talking about overactive bladder and urgency and frequency, and some of the bloated constipation symptoms. The urologists are just throwing these medications for overactive bladder when indeed they do need an exam. And it may heighten your suspicion with the symptoms to go for some screening. So definitely oophorectomy after menopause is not associated with a decrease in breast cancer risk. We want to catch these early before the horse is out of the barn. So again, breast cancer is very common. Breast cancer is 1 out of 8 women. Ovarian cancer, 1.5% lifetime risk by the time you're 80, so that's 1 out of 70 women. So we're talking about removing your ovaries prophylactically, particularly in the BRCA carriers, but the prophylactic reduction for a 1 out of 70, that's weighing the pros and cons, and there aren't a lot of women who are prophylactically for 1 out of 8, which is much more common, removing their breast. And I think the reason is because your chance for death from ovarian cancer seems to be greater when you compare it with the cancer, even though the incidence of new cases is higher, the risk for breast cancer. So, it's all in there, but if ovarian cancer is so bad, and the only way to really prevent it is why not remove the ovaries on everybody? So why not? Here are all the cons. And this is, a lot of it's based on this modeling study by Willie Parker, who's in the Kaiser system, out in California, and Jonathan Barrett, who's GYN oncologist and chair at Stanford. And here is the most important graph from that study. And it's a Markov model, and you can see these are women on the bottom who have ovarian conservation, so their ovaries are in place. And then these are women at the top with the circles who have their ovaries removed. And looking at age 40, we have significant risk for death, and mostly death related to cardiovascular disease for women who have their ovaries removed at a younger age. So while you're decreasing their risk for ovarian cancer, their overall death driven for cardiovascular is increased, and it only crosses in the 60s. So it's around 64 right here that they cross. And so that if you're taking the ovaries out in these younger premenopausal women, you must understand and have a discussion about their cardiovascular risk and have a pretty good reason to do so, given what I'm going to tell you about sexual health, osteoporosis, and your mental cognitive function. So again, these are based on modeling, it's based on published literature, it's not based on real patients, an observational study or prospective cohorts. But women who have their ovaries taken out at less than age 55 have an almost 9% excess risk for death, mortality, and those who have it under age 59 have a 4% excess risk of mortality. So it doesn't cross the line for the excess till you reach about 64, 65. So you still have to have this conversation, I think, even with the women who are postmenopausal, but the early postmenopausal. And now think about that, because also think about our largest randomized trial, Women's Health Initiative, on 160,000 patients where the average age was 62. So it doesn't help us a lot in dealing with these premature ovarian failures or surgically induced menopause patients. That's a complete bugaboo. However, the Mayo Clinic has helped us out a little bit in looking at their trial of women who had ovaries removed at an earlier age, and those who got the estrogen replacement versus those who didn't. So the referring dots are the referral patients with no BSO. BSO treated is above the straight line, and the darker line is BSO not treated. So it appears that you have a lower risk for survival or higher death if you get the ovaries removed and you're not estrogen replaced. Now remember, obviously if you get your ovaries removed, more likely than not you have your uterus removed, so you just need estrogen only, not estrogen and progesterone. And it might be the combination with progesterone that may have a greater cardiovascular risk. So the Nurses Health Study looked at women. There were 16,000 in the, this is a very large observational, not randomized trial, of 16,000 who had BSO versus 13,000 who had their ovaries in place. And the risk for heart disease and lung cancer, there was a 17% higher risk in those who had their ovaries removed. The risk of breast and obviously ovarian cancer and total cancer, however, were overall decreased. And basically the upshot here is in red, that for over the 35 years, one additional death would be expected for every 9 ovaries removed, or 9 women who had ovaries. And in no age group was getting your ovaries out actually increasing your survival rate. In no age group, but that was more observational. So, you know, oophorectomy as a risk factor for coronary heart disease here. This nice review article in the Gray Journal by Jacoby says that the effect and the existing evidence is essentially inconclusive. Again, there's pros and cons, and another con here is osteoporosis and the risk of fractures. So Atkinson says, we enter the world through the rim of the pelvis, but frequently exit through the neck of the femur, because we know that osteoporosis can lead to falls. Falls can lead to hip fractures. Hip fractures can lead to death. And in fact, my grandmother did die from osteoporosis. She fell, got a hip fracture, was taking multiple NSAIDs, and then died like 6 months later from a terrible GI bleed. So yeah, that actually rings true to me as well. Now cognitive function. Now this slide is usually used for sex. That men, we're always thinking about they got one button you can press. And then women are much more complex. There's lots of buttons and gadgets and gizmos and lights and stuff. But really it just has to do with the female brain being a little bit more complex. And that there seems to be an association with removing the ovaries and your risk for dementia or declining cognitive function. So this review, which was referred to by Roca, seems to be showing, and then you've got the WIMS data from the Women's Health Initiative on memory impairment as well. Again, pretty negative on cognitive function. Testosterone deficiency, Jan Schifrin, very involved with NAMS and whatnot. She, talks about hyperactive sexual desire, low libido, and the fact that we do not have any FDA supplements for this. People are getting compounded stuff, micronized testosterone, measuring testosterone levels, bioidenticals. I'm on the committee that was writing or reviewing that other committee opinion on bioidenticals, and having reviewed the evidence, honest to God, we don't have a lot of really good level 1 evidence. So the truth about hormones, the truth about it is what we have on the FDA approved stuff, and certainly Prempro, but we don't have a lot of truth about testosterone and the bioidenticals. And so we know that there are a lot of women who get the risk-reducing self-oophorectomy and have sexual complaints. Not only the dry vagina, painful sex, but the low libidos related to the lower testosterones. So again, the data from the Women's Health Initiative with regards to replacement, because the age was 62, you're dealing with a population that may be 40, 42, 45, or below 50. That's a completely different population, and we're okay with replacing the estrogen for the prevention of heart disease and the prevention of osteoporosis in that group. So those are factors that we consider. Age, your genetic risks, obviously very late or postmenopausal, neuropathy in 1s or 2s, take the ovaries out, but your predisposition to atherosclerosis, cardiovascular disease, osteoporosis, whether or not you had endometriosis, have pelvic pain that may be very difficult, even diverticulosis. If you're going to remove one ovary, we usually remove the left because of the colon and the diverticulosis and the problems with that. And in regard to sexual function, these are the conversations when someone says, oh, by the by, Dr. Glazier, while you're in there fixing my prolapse, what do you want to do about my ovaries? So the risk for reoperation from stuff like PID and pelvic adhesions and endometriosis is up to 7%. It's much easier to take them when they're still attached to the uterus as opposed to having to go to fishing for them by the ureter or by the pelvic sidewall. So we do talk about heart disease, cognitive impairment, long-term survival, which seem to be negative except in the population of BRCA. So in summary, there's level 1 evidence that estrogen therapy has no increased risk of breast cancer and heart disease, though there is risk of a stroke and blood clot, and this is Women's Health Initiative in women 50 to 79. There's level B evidence that risk-reducing VSO should be performed in women who are the carriers of BRCA1 and 2 after they complete childbearing and before the age of menopause, and there's strong consideration should be made to retain the ovaries in pre, and I would even say some perimenopausal women. So for premenopausal women, leave them in, unless there's a strong family history or personal history suggesting the germline mutation. Perimenopausal, consider other risks. In postmenopausal, but before age 65, when that all-cause mortality increases, consider sexual function, consider cognitive function, consider heart disease, I would say. And over the age of 65, I mean, you've got another 15, 25, potential years to live. You can probably remove those with less concern. So that's the end of the talk. Hopefully we have enough time for questions. I think we're just about time. 10 minutes. Thank you. Hi, Beth.
How would you counsel a woman